Thank you everyone. And the main purpose of this talk, I initially thought there would be no one in the beginning. So I will give some introduction. Then senior, but I'm so happy to see the whole crowd here. So I'm not going to go in depth because everyone knows about what is oxidants and antioxidants. My main purpose is that to bring about there are few endogenous and exogenous stuffs, oxidants. What is antioxidant? Because everyone knows what, like how it is happening. Or my main intention is to prove that when you want to bombard the patient with a lot of antioxidants, it is detrimental because few oxidative stress are essential for general well-being of the sperms. People unscrupulously they give antioxidants twice daily. They think the higher the dose, the sperm swims much better. It is not the case. Lifestyle matters. Once it is not fixed, because we don't spend much time with the patient. When the sperm count comes, we give a diagnosis of OAD. Patient knows it. He is googling it. He comes and says, "My thing is slow. So what I can do now? There is a whole of ads going on. Sperm count is low. You boost it. So again, we're going to give the same antioxidants. What justice we give for the patients over there is only these three things are sufficient for the patient to start with. There are few things which you have to understand that it's called as unexplained male infertility, where there are normal seven parameters, but again the patient is unable to conceive, and there is an idiopathic infertility where we have an absent altered seven parameter without a probable cause, but there has to be an absence of the female factor as well. So this brings the attention that sperm function test. Only by doing the spermiogram, it doesn't mean that, because there was previous concern that basic analysis is enough and we don't have to go to these tests initially, and if the patient is not conceiving, you can send them for IUI or IVF, and if they are failing in the ICSI, then you test them for a sperm fragmentation or otherwise. But things are changing now. I just want to bring to notice. So we have this membrane indicator, it's called HOS test, and we have multiple things called oxidative stress indicators. We have this indirect test, which is most commonly used, the peroxidase test, and we have the direct test using the chemical Otherwise, we can measure the TAC score or the newly called MIOXIS, oxidative reductive potential. And to test the DNA integrity, we have this DNA fragmentation index and high DNA strength, which is called HDS. The most commonly done and very little is called as sperm chromatin dispersion, and is done by a manual method. But I think we have to progress beyond that, and there are multiple things where we can do SCSA or channel and comment, or they are considered as a research tool. Madam is she'll there about that. But when it comes about this DFI, my take goes on. If you are capable of doing an SCSA for the patient, it is much preferable than a SCD, because it gives more accurate thing. Why? Because we can tell the patient this is what your actual DFI is, and what are the problem causes, and what is the probability of the pregnancy you have. Because when the patient comes, you will ask one question: say, if you give the medication, will it cure? You can answer that. How long will it take? You can answer that. So then what will be the patient? Taking the patient. So these tests will give us some clues, some probability that you have the percentage of success of 30%, 20%, or 100%. If it is coming with the varicocele, do you want to do a surgery or not? Because varicocele is again a big topic question, because it's highly controversial. People do surgery, but when we have a additional test like DFI, you can always tell there can be a probability of a varicose surgery which can give some benefit before optimization. And this is a relatively new concept introduced by Dr. Ashok Agrawal. It's called as male oxidative stress infertility. I'm not going too much into that. So he claims this MOXIE is also a big leading cause for infertility. And as I told you, how much ROS is too much, because the physiological level of ROS is required for capacitation, active reaction, ooze fusion, and many more things. And so coming to the pharmacological thing, I'm basically a pharmacologist over here. So these antioxidants are nutraceuticals. What is nutraceutical? Nutraceuticals are medications which are escaping the drug regulatory property in the different way. That means what? When you're going to give a drug, it has to cross phase 1, phase 2, phase 3, and phase 4. But if you have a neutralizing, it is a supplement. You can tell it is given as a recommended daily allowance. Huge business market. Profit margins are so high. And you can see many players who are entering the field. This is a welcoming move in the field of India because India is welcoming FDIs. That is the foreign investment. But still, it is being regulated by the Food Safety Authority here. And the caveat here is it doesn't require PK studies. Any drug, it requires a pharmacokinetic, pharmacodynamic study to prove its efficacy. But here, what is said, my drug is superior, my brand is superior. I am man with different. There are no claims for that. And there are no pharmacovigilance studies. Most commonly, you give antioxidants, people might complain of insomnia because you give this antioxidant by night. Patient is energized, he doesn't sleep. And he can give a history of loose motions where he comes with L-arginine. So these are all unrelated thing. And so these things people will know. So how does it act? So I'm not going much into that. And we all know about this CoQ, arginine, all-carnitine, L-carnitine, astaxanthin. The issue is we need to segregate which type of combination is better for that particular patient. Because we see a lot of nowadays advanced semen analysis giving that the sperm head is like this, sperm neck is like this, the tail is not moving, it is having HOS. But after seeing that, are we able to give the drug specific for that, or only tell the patient this is, you have these bunch of abnormalities, so it is doubtful, you take this drug, please go on. So again, I believe sometimes we don't do the justice for the patient. So these are things you can give, you don't know that. Zinc and so I just want to bring this notice because when there is a varicocele infertility, this has some kind of evidence where when you going to give ASM, it is going to increase the sperm patterns, very specifically in varicose issues. And when there is increased viscosity, we always tell that there can be an issue of infection, but we can always see viscosity increase, but infection is not there. It can some other causes, so you can give these kind of drugs. So folate, B12, I'm skipping this. Now, what do with this ROS and DFI? So you got to think, when there's increased ROS, it can be due to the infection or even the abnormal sperms. When the sperm is not growing, it is also be having a detrimental effect on the growing sperms. So it's going to drag it up. And when it comes to DFI, when there is a poor DNA packaging, it gives immature sperms. So when you can see when the count is normal, but when the DFA is high, you can always see that like this for that. I'm not going to tell this all mean any expert level andrologist can catch this, but how many good centers are there who can segregate this kind of thing? So I'm focusing more on people who have a good amount of patients, but not a proper andrologist setup. But we want to do some justice for the patient because we don't want to refer them. We want to manage them. So how to manage it? We have to have some clues. So we need to check both DFA and ROS. And this is what I want to give an intro. So from this, we have given a schedule that whether DFA is beneficial, whether ROS is also beneficial. If both are normal and still the patient count is low, whether there can be a genetic influence, and how to monitor this sperm optimization. We should fix a target. We could manage with IUI or ICSI, then how to give medication, and how long to give medications. Then we need to see like which sperms are better for ICSI or whether ejaculate or testicular. Then comes with a scope of testicular rejuvenation with the upcoming regenerative medicine therapies. And I welcome you all again. Thank you.